I had a cat named Lillie who was diabetic, and one day I noticed she was very lethargic, and finally I couldn't wake her up, so I took her to the emergency room, and it turned out she had diabetic ketoacidosis. She ended up in the intensive care unit. It cost me $2,400, but she had once saved my son's life when he was a baby, because she had woken us up in the middle of the night when he was having trouble breathing in the crib. So I figured I owed her. So she survived the ICU year. I'm a couple of days in the ICU, and she lived another 2 years, so all is well. Another time, I gave her nighttime insulin shot, and I opened the door to get the mail or something, and she ran out. And at night, I couldn't find her. She's a little black cat. I couldn't find her. I stayed up till 2 calling for her. She wouldn't come in. Went to bed. The next morning, 8 o'clock, I opened the door, and there she is on our front, step, completely cold, all stretched out like long cat, and stiff. And I thought, oh no, it's a disaster. When I was an intern, medical intern, one of the things I had to do was pronounce people dead. And one of the last things that goes when you die is something called the corneal reflex, where you take a little string or a piece of a Kleenex or something and you touch the cornea. And the corneal reflex makes you blink when you touch someone's cornea. So if that's still there, they're not quite dead. Not quite dead yet. So I touched her cornea, she blinked. I was like, so I jumped in the car, drove over to my vet, the office 4 minutes away. And I run in. I'm like, gave her insulin she didn't eat, blah, blah, blah. And hand Lillie to my vet. He takes the cat. She's like stiff and cold. He said, this cat is dead. I'm like, no, corneal reflex. He's like, So he takes her into the back of the office, and 10 minutes later, they say, why don't you come on back? And there she is. She's all happy and purring and just her normal self. And all they'd done was they'd given her a big bolus of subcutaneous sugar, dextrose, IV, subcutaneous in cats, just easier. And she was fine. So hyperglycemia with diabetic ketoacidosis, much more common in type 1 diabetics, intensive care unit visit. Hypoglycemia, if they're young and otherwise healthy, give them something sugary, back on track. I'm going to talk a little bit about the pathophysiology, about diabetes, mellitus, type 1 and type 2. And then we'll have in part 2, we'll talk about the drugs themselves in a little more detail. Right. The pancreas is the organ we're going to talk about in terms of diabetes. We've already talked about the exocrine pancreas. Exocrine means squirty, like you can see the gland squirting with your bare naked eyes. So the squirty exocrine pancreas is the part that squirts bicarbonate and enzymes into your intestines. The endocrine part of your pancreas is the part that squirts hormones into your bloodstream. So endocrine means hormones into the bloodstream, where it goes around your body and then binds receptors. So you're quite familiar with that because that's how most drugs work, right? So lots of different hormones the pancreas makes, but let's just talk about insulin and glucagon. Glucagon increases the amount of sugar in your blood, and insulin decreases. And when I say sugar, I'm going to be talking about glucose, because that's the kind you... There's lots of hormones from other different glands that increase your blood sugar. Glucagon from the pancreas, epinephrine from the adrenal medulla, right? You need epinephrine because you need sugar when you're running from a bear. Your organs need oxygen, they need sugar. So that should make sense. And then cortisol helps you when you're fighting injury or inflammation. When you're fighting injury or inflammation, you need sugar. You need glucose. Thyroid and growth hormone also both increase with glucose. All right. Only one hormone reduces your blood sugar. So this is just like with blood pressure, where most things in your body increase your blood pressure because you have to have increased blood pressure most of the time, because if your blood pressure goes down even once, you pass out. Same thing with blood sugar, right? So almost everything in your body is geared towards increasing the amount of sugar in your bloodstream. There's only the one thing, insulin, which reduces your blood sugar, because even one time of passing out, being unconscious around people you don't trust, is a bad thing. You'll either be eaten by lions, or your iPhone will get stolen, or something terrible. All right. Now, in a healthy person, blood sugar level is relatively constant. It usually hangs around 80 to 100. That doesn't mean that right after a meal, the sugar in your body disappears. It's just that the amount of sugar in your bloodstream goes down because insulin is allowing the sugar to go into cells where it can be used, or it's going into the liver or the muscles, where it's going to be stored in the form of glycogen. So here's a little graph showing the time of day with different meals. So this will be over the course of 2 days with respect to the blood glucose. So in pink here, I've got the normal range, which is 70 to 120, whatever. Just showing that with each meal, you do get a spike in your blood glucose because you ate some food. The glucose got absorbed in your body and went into your bloodstream, and then that triggers the release of insulin. Or rather the ratio of insulin. So the ratio of insulin and glucagon is what matters, so you have more insulin than glucagon after you've had some food. And then that insulin helps reduce the level of glucose in your bloodstream, and all is well. In a diabetic, the blood sugar is all over the place because it's not being regulated by insulin. So it'll eventually go down because you haven't eaten for a while, right? I mean, if you don't eat at all, then your blood sugar is going to be lower because you haven't eaten. But it will increase with each meal, and then of course the more you're snacking and eating throughout the day, the higher your sugar. If you think about it, our ancestors who lived in caves or were hunter-gatherers, they weren't eating all day snacking because there were no vending machines. They'd eat like once in the morning maybe, and then they'd eat when the hunters got back, and that would be, it. Sort of this constant eating all day is a sort of a product of modernization. All right, so diabetes, I'm sure you know, is a very common disease, and it's a disease of modernized first world countries because especially type 2 diabetes is related to obesity. So it's hard to be obese when you are starving. So in countries where there's a lot of people starving because of famine, they tend to not have the type 2 diabetes. Unfortunately, there's lots of different kinds of there's different levels of diabetes. It used to be we just called people with diabetes diabetics. But now, because of the way the guidelines are structured and because of the way insurance is structured and because of the way we treat different degrees of diabetes, diabetes is subcategorized into sort of pre-diabetes or metabolic syndrome, and then mild diabetes, bad diabetes, super awful diabetes, etc. I'm not going to get into that. That's something you can learn later. But now, diabetes mellitus is the same root word is like mellifluous, like something that's sweet, like a sweet melody, mellifluous. Diabetes mellitus means sweet urine. You may have already learned about diabetes insipidus, which is very bland urine. You may have also heard that the name was given because somebody saw ants sitting on a diabetic's urine. That is total BS. In the olden days, if you look at the writings of Pliny the Elder or whatever from the ancient Greeks, they were constantly drinking urine from different animals. They thought that would cure all sorts of conditions. And there's a whole movement of people in various countries where they just love drinking urine of various animals or themselves. So, people drink weird stuff, right? Alkaline water, right? Okay, all right. So according to the ADA guidelines, and for many years now, there's 4 main categories of diabetes. There's the type 1 diabetics. Those are the ones who don't have any insulin. There's the type 2 diabetics. Those tend to be the ones who are obese. There's gestational diabetes, and then there's other weirder, less common causes of diabetes. So type 1 diabetes, which you'll often see abbreviated in medical charts as IDDM or insulin-dependent diabetes mellitus, that's really not a good name or term for that because you will see type 2 diabetics and other types of diabetics using insulin. So type 1 diabetes specifically means the types of diabetics that have no insulin of their own because their pancreas, the part of their pancreas that made insulin, is destroyed. Right? So this is a plain old, straightforward hormonal disease where they're missing the hormone they need, so you just give them the hormone. Easy peasy, right? Missing the hormone they need, give them the hormone, boom, done. He's happy. Well, pretty happy. Type 2 diabetes, which you'll also often see written as non-insulin dependent diabetes mellitus, NIDDM. Again, use type 2, that's a better way to refer to it. Type 2 diabetics are the types that are obese, and the idea being that high blood sugars throughout the day cause your pancreas to sort of squirt out insulin all the time, which it should normally do. That's not the way your pancreas is built. It shouldn't be doing that. So because you have high levels of insulin all the time, you have downregulation of the insulin receptor. And as you know from our very first lecture, when you have downregulation of insulin receptor, of any kind of receptor, you can't have maximum efficacy. So you have a loss of insulin effect. There's gestational diabetes, which is any kind of diabetes or regular diabetes that is diagnosed in the second or third trimester of pregnancy. This increases that patient's risk for diabetes later in their lives. Generally is treated, according to current guidelines, with insulin to begin with, or rather diet and lifestyle changes first. And if that doesn't work, then insulin. If that doesn't work, then you can go to a few oral drugs, cautiously to those drugs. But pretty much probably want to try not to have to use this if you can. And then there's drug-induced diabetes, and we've talked about some drugs already that induce diabetes, like prednisone, right? And then, or systemic steroids. Also, thiazides can increase blood sugars and also blood lipids, right? Beta blockers could do it. Usually cured by discontinuing the drug, but then you have to figure out what you're going to give the patient instead of. This table, I believe, is in your handout, and it's just a table for people who like tables. So, la-di-da. Diagnosis of diabetes is usually made a couple of ways. One is through what's called a fasting blood glucose, which means you don't eat anything after midnight, you come in the morning, and they check your blood sugar. This is for people who have never been diagnosed with diabetes. These are not people who are already on treatment for it. Or you can check a person's blood sugar randomly or 2 hours after a glucose challenge. A glucose challenge means that you give somebody something super sugary to drink, and then 2 hours later you check their bloodstream. So if you drink a Mountain Dew and eat 14 Milky Way bars, an hour afterwards, your blood sugar should be back to, a reasonable level again. If you have diabetes, that means that your body's not able to handle that kind of a challenge. And then glycosylated hemoglobin. So glycosylated hemoglobin is kind of awesome because it allows us to tell what the blood sugar level has been like for that patient for the last couple of months. So we don't have to harangue our patients about, like, what's your blood sugar been? Are you being a good patient? Did you check your blood sugar? Blah, 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 blah. You don't have to do that. You check their blood sugar, their HbA1c, and their HbA1c is super high if it's like up here in the 14 range, well, then you know that their blood sugar has been around 380 for the last 2 months, which is super high. That's like not good. So you can really get an idea of how well their blood sugar has been controlled and how even it's been, if there's been lots of peaks and valleys, from the HbA1c. And it's very well documented that the lower the HbA1c is in a patient, the less chance they're going to have all the horrible side effects of diabetes, which are you go blind, you lose your kidneys, so you have to be on dialysis, you lose your toes, your feet, your bottom legs, your knees, your legs, you get amputations, you get weird pain that's difficult to treat because it's in the nerves, dementia. What happened to my cat Lillie, what killed her off was the diabetic gastroparesis, which is where your guts just stops working, and we talked about treating that with Reglan. So there's lots of horrible things. Diabetes, don't get it. If you have a family history of diabetes, just don't get overweight. If you are overweight, go on a diet. Now, two things can happen when you have diabetes. One thing can happen when you have diabetes, which is something called diabetic ketoacidosis, which happens when your blood sugar gets super high, all right? And I can give you a link to a video that can explain that at length. Let's just cut to the chase. So if your blood sugar gets super high, when your blood gets to your kidneys, where it's going to get filtered, it gets filtered, and then your bloodstream takes back what it wants, and everything else gets washed away as urine. Well, your body doesn't need so much glucose. It's not built to take all that glucose back into the body. So a lot of it ends up staying in the nephron. And glucose, it acts just like the sugar alcohols, the mannitol, sorbitol, xylitol, the glycerin, all those things we talked about as an osmotic diuretic. That glucose stays in the nephron and it sucks water along with it, just like an osmotic diuretic. So because of that, the patient loses too much urine and they get dehydrated. High blood sugar levels will always cause this, and in fact, it's one of the ways you can diagnose a diabetic who has not been previously diagnosed. So, if you have a type 1 diabetic, a little kid who's suddenly peeing constantly and having to drink water constantly to like stay hydrated, that can sometimes be an indication that maybe their blood sugar is too high. All right, so if your blood sugar is high and you're constantly peeing, you get dehydrated, and then other bad things happen, and it all ends up with you getting a metabolic acidosis. A metabolic acidosis, all that means is your blood pH went down because of something going wrong in your body. All right. But diabetic ketoacidosis, more common in type 1 diabetics, and you will end up in the intensive care unit if you have diabetic ketoacidosis. It's not something you can fix with a big shot of insulin, and I'll explain why in the second video, but it mostly has to do with the fact that insulin moves glucose into your cells, but it also moves potassium into your cells, and some other stuff happens. So you can't just give somebody a giant shot of insulin because their potassium will disappear. And you can't just have someone's potassium levels disappear because their heart will stop and bad things happen. It's a big deal, All right, now if you start somebody on insulin or oral hypoglycemic, you're at risk of the patient becoming dangerously hypoglycemic. So hypoglycemic, in fact, that they will pass out. So hypoglycemia is a blood sugar less than 70. It can happen either if the patient has too much insulin or a secretagogue. A secretagogue is a drug that makes you secrete more insulin, hence the term secretagogue. Or if you have a patient who gets their insulin but doesn't eat until afterwards, if you give a patient their insulin but they didn't eat, then the insulin brings the blood sugar down, but there's no food to counteract it, so the blood sugar gets too low. So if the person is otherwise healthy, like a young, say a type 1 diabetic who's fairly young, and they get hypoglycemic, if you can get sugar into them, they'll usually wake up and be okay. If you have a patient as long as the blood sugar level wasn't too low for too long. If you have a patient who's older, who's got a lot of other illnesses, and maybe they have bad heart, bad coronary arteries or bad other things, then being hypoglycemic might be dangerous for them because they've already got organs and body parts that are sort of on the edge of being injured. And also when you pass out, you hit your head and you could break your hip and all those things. So right? And also when you pass out, you can be eaten by a lion. And if you're an adult with diabetes and you get hypoglycemia, be like you're driving along the road and you pass out, you can hit a pole or hit a small toddler or a cute puppy or a busload of kittens or something like that. So, you don't want patients to become hypoglycemic ever if you can avoid it. You don't want patients to. Symptoms of hypoglycemic, if you've ever been hungry and you forgot to eat, you probably know some of these. First of all, you can feel hungry. I find if I get too hypoglycemic, I just get nauseated. Symptom of headache, get all sweaty, shaky, your heart can pound, right? You feel weak and awful. Remember that the symptoms of hypoglycemia can be blocked with beta blockers. So you don't want a patient who is at risk for dangerous hypoglycemia because they're on insulin or a secretagogue. You don't want those patients on beta blockers if you can help it, because those patients might get hypoglycemic and not have any of the warning symptoms, so they won't know, I'm getting hypoglycemic, I better have some, Pepsi or a glucose tablet, because you don't want them just sitting there, la, 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 and they pass out, and then they hit their head and whatever. Or maybe they live by themselves and they get hypoglycemic, and then somebody realizes they're missing a week or two later and they come in and they find them in their apartment, eaten by their cats or something. You don't want that. So if somebody gets hypoglycemic, the easiest way to fix that is to just give them some glucose or sugar or something sugary. If they are still conscious and not confused or sleepy or look like they're about to pass out, you can give them glucose pills or something sugary. I had a diabetic friend who loved Pepsi. That was his favorite treatment for hypoglycemia. If they are unconscious, do not put anything in their mouth. In the movies, they do that all the time. That is the wrong thing to do. Just give them something IM, like glucagon, or you can give them IV dextrose, dextrose just means D-glucose. It's just glucose, IV glucose. Absolutely do not put anything in someone's mouth when they're unconscious, food-wise or drink-wise. And usually they wake up pretty quick. The blood sugar comes up, and if they didn't have any underlying health problems, they should be okay if their blood sugar wasn't too low, and they'll be all right.